Good morning, everyone. We would like to start the last day of APCCC 2024. We are very happy to see so many people still in the room, and I'm sure there's more outside that will join us very shortly.
So thank you very much. Also from my side, Saturday morning, I'm really impressed. And thank you very much, Misha and Andy, for chairing this short session. Thank you.
Thank you. We're excited to co-chair this first session of the last day of this amazing meeting. This session is focused on advanced prostate cancer, a range of topics from germline, somatic testing, and aggressive variant. I don't know. Do you want to say a few words?
Yeah, good morning. And our first speaker is Heather Chang from the University of Washington, who's going to teach us about who should undergo genetic testing.
Okay, good morning, everyone. Before I get started on my slides, I want to extend a very sincere thank you to Silke and Aurelius and the APCC team. This is always just an amazing meeting, and the execution and the love is impeccable. So thank you for all your hard work. All right, I'm going to talk about who should undergo germline genetic testing. Here are my disclosures. I think the one I'd just point out is I am a medical oncologist. I direct a prostate cancer genetics clinic, and my clinical and research focus centers around genetics, and so I'm very passionate about this, and I hope I'll convince you that you should be too. So here was my task for the morning, the next 10 minutes or so: which patients need germline genetic testing, and then which findings on tumor genomic profiling require genetic counseling and/or confirmatory germline testing. I'll speckle in discussions about relevant clinical trials because I think that matters in consideration of how to make these decisions, and then end with some take-home points on how do I do it in my clinic. So let's start with which patients need germline genetic testing. So I think in order to answer this question, it's really important to ask the why. So why should we even think about doing this? Why is this important? Number one, it may help the patient better understand the risk of prostate cancer and other cancers if it's in the pre-diagnostics or pre-prostate cancer risk state. It may help their family better understand their own risks and potentially have options to reduce their risk of developing cancer or diagnosing cancer earlier and having better outcomes. And increasingly, as we heard yesterday in some really excellent sessions, it may help prognosticate and also identify additional treatment options, such as PARP inhibitors and platinum chemotherapy, and we'll hear more from Dr. Aparicio on other things that are in the pipeline. So treatment for patients and their prostate cancer. Here is an incomplete but sort of snapshot of some of the prevalences of germline mutations across prostate cancer disease states, which guide some of the recommendations of who and how we should think about germline genetic testing. So this is these cohorts are unselected, largely unselected for family history of cancer. So this is looking at personal history of prostate cancer. So in the top row is metastatic from an international consortium. Many of you in the audience were involved in this, and there was 11.8% in metastatic disease with germline DNA repair mutations. That was in 2016, reported by Pritchard et al. And then MCRPC, Dr. Castro, I think, is in the audience, and Pro-Repair B had 16.2, and then CSPC in a Mayo institutional series, 9.4, and then a pooled prospective neoadjuvant study series by Jacob Burchak and Marilyn Taplin showed 9.5%. In the localized disease setting, 4.6% TCGA, and very low risk in active surveillance cohorts. It's pretty low, around 2% or so. Those, I will say, is limited to BRC 1 and 2 and ATM, and those are very small cohorts, but the available data. So the justification of personal history of prostate cancer comes from an approximate 10% prevalence, and it justifies testing by personal history of prostate cancer. And then I will just also emphasize that if you also have a family history of cancer, that increases your pre-test probability of discovering a germline mutation. So that's, I think, the argument for saying we should be offering germline testing to people with, in the red box, intermediate high-risk localized disease, but also in the localized low-risk disease if they have a family history of cancer. So family history still matters. There's been a number of series saying it's imperfect and we miss people. Yes, that's true, but it's still important to ask about a family history of cancer, especially prostate, breast, ovarian, pancreas, colon, both sides of family, male and female, age of diagnosis, if the cancer was the cause of death. And I encourage patients, and I do this for all the patient education sessions, tell your patients to know their family history. If they don't know it, ask. And if they know it, then share it with their other extended family members, because there's a generation of people that didn't really talk about their family cancer history, and so this is really important information because there's more to be done about it. Asking earlier is better, and we can all of us, take ownership of this. And after yesterday's session, I actually plan to start asking not just about family history of cancer, but also about cardiovascular risk disease, because I think that's important too. So, sure, family history, it's imperfect. We miss people. We can't rely solely on family history, but it's also no cost, low cost, easy to implement, and we can do it in any resource setting. So I would say, let's do better. What is the clinical actionability for the patient? Context really matters. So I would say, this is the disease spectrum. We have early detection on the left side, moving to active surveillance, definitive treatment, surgery, radiation, curative intent treatment, and then advanced disease over on the right side. The green boxes right now are where there are guideline recommendations for management changes based on germline findings. So along the bottom is all the members of the team who should be thinking about this. I'm a medical oncologist, so I think a lot about the MCRPC setting, radiation oncology, urology, primary care also needs to be integrated in thinking about how we do this together. So now I'm going to talk about early detection, screening for prostate cancer. I'm going to summarize, this is a busy slide. The main point is these are some of the major guidelines from EUA, AUA, NCCN. Basically, if there's a germline mutation, predominantly, especially BRCA2, but some of these other ones listed here, we should be offering PSA screening around age 40, 45, and NCCN's a little bit more granular, BRCA2, BRCA1, ATM, check 2. The strengths of some of these is still in development, but I think especially if there's a family history of prostate cancer, this is something we should really be talking to our patients about. These are informed by results from the IMPACT study. Many of you in the audience may have been involved in the IMPACT study led by Roz Eel and her team, but many people internationally that guide those recommendations. And I don't have time to go into the details, but you can refer to that, refer to the references there. This also is a busy slide, but the point here is that there are now more germline relevant clinical trials for prostate cancer screening. So I know we weren't supposed to make our decisions based on clinical trials, but in our academic practices, it's also important to engage patients in clinical trials. So these are some of the available ones: Ontario, Canada, Israel, the NCI study in Bethesda. We have a study called Patrol, which is Seattle, Portland, Chicago, more sites coming on board. Boston has a study, and the VA is anticipating a study called Progress. So this also adds to the actionability. Patients can enroll on trials in order to participate and move the needle further. So we talked about early detection, and then I just mentioned, but I'm not going to go into detail, the metastatic castration-resistant prostate cancer setting, where now, since 2 years ago when we were here, there have been even more options in terms of PARP inhibitor approvals and combination therapy. So that is clearly very actionable, right? So really exciting. So germline-informed guidelines for prostate cancer treatment. Here it's just ESMO and NCCN. Basically, the recommendation is family history of cancer, as well as patients with metastatic disease, really referring to, I think, the actionability at the advanced disease state. And then in the MCCN guidelines, it's where it is likely to impact the treatment or the clinical trial options. And so that's where I think there's been a lot of movement, which is exciting. So again, family management, implications, treatment options have expanded in MCRPC. Management modifications are debatable in the very low-risk active surveillance setting. I'm not a urologist, but I know there's some debate about whether active surveillance should be offered BRCA2 patients, but certainly an awareness of it. And then new on the scene, clinical trials in the curative intent setting for high-risk localized disease. In addition to, for BCR, MCSPC, and MCRPC. And I think this actually personally makes me very excited. And so here are some of the selected trials. These are neoadjuvant trial leveraging the genomic profile or the germline finding of patients. This is an opportunity to use precision treatment to hopefully improve curative outcomes. So I've got GUNS. Dr. Gleave is leading that, Canada and US. Dr. McKay is leading Neptune, neoadjuvant PARP inhibitors, and SWOG 2210. I've been leading with the help of my SWOG colleague for BRCA1 and 2, and that's carboplatin. So these are exciting. Hopefully they'll show us something, but I think it helps with the actionability in between in that orange box. Okay, which findings on tumor genomic profiling require genetic counseling and or testing? So a lot of discussion about, we want to do tumor testing. Why is it important to do germline? Because it helps the patient and it helps their family. So really these are findings that are actionable in other realms. So BRCA1, BRCA2, ATM, PALB2, CHEK2, HOXB13, Lynch syndrome genes. If there's MSI high or mismatch repair deficiency, you should refer or think about confirmatory germline testing because it matters a lot for management of the patient, for screening of the other cancers, and also for their family members. Really quickly, a patient case. This is a patient who has a very strong family history of cancer. He was diagnosed 61 with Gleason 6 and then developed MCRPC by age 80. He had prior germline testing in 2016, which was unrevealing. He saw me in my genetics clinic, and then we retested his tumor and his germline. He has a reduced penetrant P53. So why is this important? Family history still matters. So even though he had prior germline testing that was negative, he had a really strong family history of cancer. The other point I wanted to make is P53 is very commonly mutated in cancer, not usually germline. But if there's a very suspicious family history or a very high variant allele fraction, that can raise suspicion that there's something germline, and we don't want to miss that. And then one other point in this, there's other studies here also from Memorial, but really quickly, Jacob Burchak also reported on a series of 100 patients that had both tumor and germline and found that tumor-only sequencing failed to report more than 20% of pathogenic variants in men with advanced disease. So it's important, but if family history is suspicious or implications are important to the patient, you still should be thinking about dedicated germline testing and genetic counseling. So, take home, how do I do it? Inquire about family history, cancer, and now I'm going to start asking about cardiovascular disease. Offer germline testing to all men with high-risk localized node-positive and metastatic prostate cancer. How much I nudge depends on the why for the patient and the actionability. Right now, it's screening, MCRPC, and clinical trials. In the future, hopefully that'll change. 2 years from now, hopefully we'll have more to say in terms of actionability. Those with tumor testing needing genetic counseling or germline testing are those who have a strong family history, irrespective of tumor testing, or tumor mutations of genes that are also actionable from a cancer screening standpoint. Those are listed there. P53, a little bit more tricky, usually not germline, but we also don't want to miss it. So seek out your genetics and pathology experts, consider family history variant allele clues. Videos, web tools, and workflows can and will help with implementation. I didn't have time to talk about this. There's been a lot of work on this. Many people in the room are doing great work to try to extend our ability to do this for more patients and to do it well. Ensure patients understand the why, then meet them where they are. And I will also say actionability and acceptance may evolve over time. So if you have the first discussion at high-risk localized disease and you don't have a trial, that's okay, but if they develop metastatic disease, then revisit this and ask again, because then the actionability changes. So lots of implications. I'm not going to go through this except for that as a medical oncologist, there's a lot of room for extending benefit. And then my last slide is a thank you slide, but there we go. Germline genetic testing in prostate cancer, hopefully I've convinced you, can be a force multiplier. Thank you so much.
Thank you, Heather. Our next speaker is Dr. Anna Aparicio, who will be talking about how non-DDR genomic alterations impact management of patients with advanced prostate cancer.
So I would spend the first 5 minutes thanking the organizers and telling you how much I enjoy this meeting, but I'm really scared of those bells, so I'm going to get on with it. Okay, these are my disclosures. So I thought we could talk about predictive markers for tumor-agnostic FDA-approved drugs, and then prognostic markers that are quote-unquote specific for prostate cancer. But the fact of the matter is that RET fusions, NTRK fusions, and BRAF V600E mutations are extremely rare in prostate cancer, so not really worth talking much about. And although HER2 overexpression has been described in prostate cancer, the pan-cancer tumor clinical trial that led to the approval of famtrastuzumab deruxtecan did not contain a single patient with prostate cancer. So I'm going to focus on MSI-high disease. As you all know, pembrolizumab was approved for tumors with tumor mutation burdens greater than 10 mutations per megabase and MSI-high as detected by a FDA-approved companion diagnostic Foundation 1. There was also approval for MMR-deficient tumors, which are shared with dostarlimab, also approved in this space, and again with a companion diagnostic of Ventana. And since their approvals, we've had a number of series in prostate cancer that have shown a response rate in the order of about 50% and a rate of durable response of 25%. In my experience, some of these responses are truly like Lazarus effects. So there are people that I've treated who had very poor responses to AR inhibition. I tried chemotherapy, nothing worked, and it was absolutely miraculous to see the response to pembrolizumab. So I think it's very important that we focus on this. But we don't really know why many of these people will not, in fact, respond. And some explanations include mutations in genes that are implicated in immune activation. However, there's also the issue of how we're measuring tumor mutation burden and how we're measuring MSI-high disease. And this is just one example of a study where investigators took DNA from a number of FFPE samples, patient samples, and looked at tumor mutation burden across 16 different assays. And you can see the variability right there. There's approximately more than close to half of the samples yielded tumor mutation burdens that might have been above or below the cutoff, depending on the assay. And this brings us to the point that it's really important that we interpret our clinical genomic tests correctly, because we think that when we get their sequencing, we have a real good view of what that tumor biology is. But the fact of the matter is that the variables in the genomic assays might actually sway us away from that tumor biology. So there are many things that we need to take into consideration. There's a sample source. Is the solid tumor? Is the circulating tumor DNA? Are you doing a matched germline sequence? Because the interpretability of the mutations that you might find can vary. How many genes are included in your panel? Because the smaller the number of genes, the less reliable your tumor mutation burden result might be, and what parts of the genes are covered, because not all of the assays that we use will cover the same regions. There are also limits of detection for individual alterations, and it also has to do with the tumor fraction that's in your patient's sample. What class of genomic alterations are being reported? A lot of the assays that are in clinical use will not report copy number alterations because they're tricky, and most will not report structural variations. And what are the criteria to use to assess variant pathogenicity? This was actually reviewed by a paper by Alexander Wyatt, which I highly recommend you go through, very informative. And so this leads me to the prognostic markers that are quote-unquote, again, specific to prostate cancer. I'm going to touch on the 3 that are listed here, well, actually 5. And just to say that while they have been linked to therapy responses and outcomes, we really do not have studies that have validated their prospective or their predictive value in terms of us choosing a therapy. So these studies are needed. I'll start with SPOP mutation. This is an E3 ubiquitin ligase adapter that it binds to substrates and targets them for degradation. And you can see many of these are AR substrates or proteins that are implicated in AR activity, including AR itself. And it's mutated in about up to 15% of prostate cancers. It appears to be more common in the localized setting versus the metastatic setting. And when it's mutated, what happens is there's stabilization of AR and there's increase of AR activity. And it has been linked in several series to increased responses to ARPs. We did not use that term at the time. And you can see in this study, for example, in metastatic castrate-sensitive prostate cancer, that the time to castrate-resistant progression was significantly prolonged in those that had SPOP mutations, as was the overall survival, but this did not apply to docetaxel. On the other end of the spectrum, we have AR alterations. These actually occur after treatment exposure, and they're frequently subclonal, different from the SPOP mutations. And they're actually the most frequently altered locus in metastatic castrate-resistant prostate cancer. The most common ones are the copy number amplifications that can be just the gene body or in combination often with the enhancer region. And there have been, again, several studies that have shown that the more AR copies you have, the worse your outcome. And that's probably because there's increased AR activity. There are then the intragenic structural rearrangements. These are genomic alterations frequently happen in intron regions, so they're frequently missed by our standard assays, and they certainly don't capture the AR variants that arise as a result of alternative splicing of RNA. But again, AR variants, there have been numerous publications showing an association with outcome and response to RPs. One thing that's important to take into consideration is that both the AR amplifications and the AR variants are also strongly associated with other markers of poor prognosis, so tumor burden, high circulating tumor cell counts, et cetera. And so we have to take these things still with a grain of salt. The last set of mutations or genomic alterations that we found in AR are the AR point mutations, and these will have not necessarily prognostic implications, but they are associated with resistance to AR signaling inhibitors, in some cases into ligand promiscuity, so something to take into account. We've heard a lot during this meeting about P53, RB1, and PTEN. And so I decided, we've heard that they're linked to poor prognosis individually and combined. So I thought that rather than show you a number of Kaplan-Meier curves, I would just point out the complexities of determining their functional outcome. This is a study that we did in patient tumor-derived xenografts. And on the y-axis is a loss-of-function transcriptional score, previously published. And on the x-axis is the log-2 ratio of the copy number variation. In red are tumors that had an abnormal immunohistochemistry for the marker, and in green, those that were normal. And so several things to point out. One is that for P53, the most common genomic alteration is actually missense mutations, but not all missense mutations are created equal. Not all of them led to a loss of function, a transcriptional score. For RB and PTEN, the most common alterations are copy number losses, and we just said that copy number losses are often not reported in our clinical assays because they're very tricky to determine. And so it's important that we realize these complexities when we're interpreting the alterations. So to try to validate the latter, the combined tumor suppressor defects, we have, Paul Korn is going to lead the SWOG 2312. And I just wanted to point out that we chose to look at the alterations by immunohistochemistry for a number of reasons. One is, again, trying to get to the business end of the tumor, but also because, that's the first one, also because the turnaround times, these are people that frequently need chemotherapy relatively quickly, and immunohistochemistry has a faster turnaround time. And lastly, because we felt it would be more applicable across the world to use this as a marker. So more to come on this. Hopefully it'll be open soon. But I think what we're seeing is a picture that Dr. Fizazi alluded to yesterday, that we can't think of prostate cancer as all one disease. It's really these subsets are emergent, and they're kind of clinically evident, but we're now putting labels on them. So those that are sort of more androgen addicted, maybe enriched in SPOP mutations, that are androgen indifferent, may be enriched in combined tumor suppressor defects. And I think it's important that we take these into account in our clinical trials specifically, and also when we're thinking about how to see all the talk about the sequencing of our drugs. While we increase the robustness of our markers, because nobody's, I think, confident enough to design a trial and apply their therapies based on the current markers, we can think of modular designs where you apply AR inhibition, and if you have an optimal response, you can apply therapy A, and if you don't, then you can apply therapy B. Just food for thought. So, in conclusion, know thy genomic test. The patients with MSI high, TMB high, or MMR deficient prostate cancer should be offered treatment with an anti-PD-1 inhibitor. Often they can be really very dramatic responses. Prospective marker selected or marker stratified studies to validate the predictive value of these other genomic alterations that we talked about have to be done. And these clinically evident distinct biologically subsets of prostate cancer really need to be accounted for in therapy development. And with that, thank you very much.
Thank you, Anna. We spared you the cowbell. But, our next speaker is Misha Beltran from Dana-Farber. Looking forward to how to identify aggressive variant prostate cancer.
Thank you very much. So as we've heard already, castration-resistant prostate cancer is a heterogeneous disease defined by genomic subtypes, but also phenotypic variants and resistance mechanisms that aren't often used clinically today to drive decision-making, but do have promise in helping optimize therapy for our patients. And in the clinic, we see a spectrum of CRPC. We see some patients with minimally metastatic disease, asymptomatic, slowly rising PSA. On the other hand, we might see patients with rapidly rising PSA, superscans, or low PSA and visceral mets, explosive disease that you kind of know it when you see it. So identifying aggressive variants of prostate cancer does have potential therapeutic implications, and selecting patients to intensify treatment for those with the most aggressive disease that need it the most can also inform rational combination strategies, targeting AR and non-AR, for instance, or targeting specific lineage programs like the neuroendocrine lineage that can arise in some tumors. The term aggressive variant prostate cancer has been used as specific clinical trial criteria for platinum taxane phase 2 clinical trials led by my colleague here, Dr. Anna Aparicio, and colleagues at MD Anderson. Here are the criteria that were used for those studies, diverse group of clinical criteria, but the idea being that maybe these atypical features can converge on biology that may predict response to the addition of platinum. One aggressive variant of prostate cancer is the small cell neuroendocrine prostate cancer variant. This is a histologic subtype that in its pure form can look and act a lot like small cell lung cancer and often loses expression of the androgen receptor. There are other aggressive features. Our list of prognostic variables in CRPC continues to grow, including the development of PSMA negative FDG avid discordant disease on PET, high ctDNA fraction, germline BRCA, somatic RB, brain mets, et cetera. And I think it's important to understand these and recognize them as they may inform our clinical studies as well as care for our patients. You heard from Dr. Aparicio about tumor suppressor losses that are enriched in patients with clinically defined aggressive variant prostate cancer and may predict better responses to the addition of platinum. When thinking about tumor suppressor losses, these are the most, RB, P53, and P10 are some of the most commonly altered genes enriched in CRPC compared to localized disease, along with the androgen receptor. And multiple preclinical studies have supported loss of tumor suppressors, particularly when there's more than one tumor suppressor loss, driving lineage plasticity and AR independence. And in lung cancers, adenomas that transform to small cell, the presence of RB and P53 alterations precedes the histologic transformation, and the same might be the case in some of our patients with prostate cancer. So how do we assess tumor suppressor losses in the clinic? Dr. Aparicio alluded to this a bit. Primary tumors are not ideal, as these can often be acquired. What metastatic tumors should we use? What time point? What lesion? ctDNA has inherent limitations when detecting deletions, and all of these tumor suppressors can be lost through copy number loss. Both IHC and genomic sequencing have been used in clinical trials. We looked at pre- and post-tumor specimens in patients treated on the PUNCH trial, neoadjuvant ADT docetaxel, and found that post-treated tumors were enriched with P53 mutations associated with gene expression changes and approaching the frequency of metastatic disease. We also saw frequent P10 loss. So P53 and P10 loss may be early events that are selected for, but RB loss is almost always acquired. Johan de Bono has showed heterozygous to homozygous evolution of RB loss with disease progression, but of note, most of our commercial assays only report homozygous loss, so our understanding or appreciation of RB evolution, I think, is under-recognized. And there are many ways to lose RB, not just genomically. You can get phosphorylation, methylation, and other ways to functionally lose RB, and complementary approaches such as looking at RB signatures demonstrated by Felix Fang and others, or IHC, as mentioned, to pick up loss of protein when there may not be genomic alterations and to complement other other in situ assays. We heard about IHC being cost-effective, easy to implement across centers, but P53, for instance, can be high with mutation and low with deletion, and I think understanding the mechanism of alteration is still very important. We saw in the hepatocentral trial that P10 loss by IHC didn't have completely the same outcome data with the NGS-defined P10 loss, and so we may need complementary assays. There are no current indications to actually test for tumor suppressor losses, but we often get these anyway on our NGS reports that we are doing to look for DNA repair alterations, and in some cases can confirm that patient that has aggressive disease. I mentioned the neuroendocrine prostate cancer variant. Lots of controversy as to how often this occurs. Part of this is because repeat biopsies are not standardly done. There's variability amongst pathologists, and there can be intrapatient heterogeneity. But nonetheless, many guidelines, including the NCCN, do endorse doing a metastatic biopsy when neuroendocrine prostate cancer is suspected, as those patients might be considered for small cell lung cancer-like regimens. We've been working with a group of expert GU pathologists and clinicians to come up with a proposed framework to standardize the workup of metastatic CRPC biopsies when neuroendocrine prostate cancer is suspected, including morphology, IHC, and proliferation classifiers. Because one could envision if we were all reporting these reports in the same way in our clinics and our clinical trials, we'll be better at understanding the clinical significance, particularly of mixed tumors. Neuroendocrine prostate cancers can lose androgen receptor and also lose PSMA expression. And there's a spectrum as tumors go from adenocarcinoma to small cell. They can go from PSMA high to PSMA low, but other markers such as DLL3 can go from negative to positive, and these are also often FDG avid, raising the exciting possibility of potentially using PET features to diagnose neuroendocrine prostate cancer. So again, these are often PSMA low or negative, although this is not universal. There are some neuroendocrine prostate cancers that do express PSMA, and not all PSMA negative lesions are neuroendocrine prostate cancer. They're often FDG avid, reflecting their metabolic activity, but this is not specific to neuroendocrine prostate cancer. There have been some reports of using dotatate to diagnose neuroendocrine prostate cancer, but has poor sensitivity overall for high-grade neuroendocrine carcinomas. And there are a number of other emerging markers on the imaging side, such as DLL3 and others, that may help us in the future. But I would say even today, if I saw a patient with PSMA low, FDG high lesions on PET imaging, particularly if soft tissue or visceral, this might inform when and where to biopsy to look for neuroendocrine prostate cancer. Liquid biopsies, transcriptomic signatures, other molecular biomarkers hopefully will help us also in the future. We've been really interested in DNA methylation, as the epigenetic landscape of neuroendocrine prostate cancer is very distinct from adenocarcinoma, and we can detect this in cell-free DNA. And working with Francesca De Michelis, we recently reported NEMO, and a targeted cell-free DNA methylation panel that's high throughput and low cost and designed to distinguish white blood cells from cancer, adeno from neuroendocrine, infer tumor content, provide a phenotypic evidence score, and infer transcriptional state. We validated this panel in multiple clinical cohorts to demonstrate its performance, and I collaborated with Dr. Aparicio here to look at patients enrolled on the carbo-docetaxel aggressive variant clinical trial and found that cell-free DNA methylation-based tumor fraction was prognostic, and the phenotypic evidence score picked up those biopsy-confirmed small cell neuroendocrine prostate cancers, but also picked up a subset of the clinically defined aggressive variant prostate cancers that may be consistent with undiagnosed neuroendocrine prostate cancer. So just to summarize, aggressive variants of prostate cancer exist, and these patients might benefit from alternative treatment strategies. The current diagnosis of aggressive disease is imperfect, inconsistent, and may encompass multiple biologic subtypes, but there are a number of emerging diagnostic tools that have been developed, and standardizing these biomarkers in clinical studies will be essential in understanding their therapeutic relevance. And ultimately, we want to know, how does identifying aggressive variants select therapy, and improve patient outcomes? And to this end, I've been excited to work with Raina McKay and the Alliance Cooperative Group on an umbrella trial where we'll be using both RNA and DNA to select patients for specific regimens based on their subtype of aggressive variant prostate cancer. Thank you for your attention. And I will introduce our next speaker, Dr. Andy Armstrong, who will talk about treatment of aggressive variant.
Thank you, Misha. And Silke and Aurelius, it's been a wonderful meeting. And, we're planning a hike later today, and I thought I'd use the hiking analogy for neuroendocrine prostate cancer. At the Translational Symposium, it was felt to be the north face of prostate cancer, the hardest to ascend. And I think you've heard from the previous speakers about the trail map, the molecular trail map to help guide us up the mountain. And so these are my disclosures. I'll be talking about how to treat prostate cancer of neuroendocrine aggressive variant histology, covering some consensus evidence or lack of consensus, how I treat patients off protocol, what's new in the past 2 years, some guidance for clinical trial leads and targets as we move towards trying to climb this wall. So level 1 evidence for treating neuroendocrine prostate cancer from phase 3 randomized trials demonstrating an overall survival benefit. NCCN and almost all guidelines have not listed any level 1 evidence. And so this is our barrier right now. This is why it's been such a formidable challenge. But the absence of evidence is not evidence of absence. We just need to try harder with bigger studies, with basket studies, and with more rational combinations. Here's the NCCN guidelines, which were just released and will be revised next month again. If you look at small cell neuroendocrine prostate cancer, certainly it's recommended, as you heard Misha say, to get a biopsy to diagnose the histologic transformation. And we have a number of platinum doublets, and the new kid on the block is Cabazzi-Carbo. As you can see from the European guidelines, we have the Cabazzi-Carbo regimen for all comers did improve progression-free survival, and the selected group of aggressive variant molecular or clinical features was suggested to improve overall survival. And so that's considered level 2 evidence, and certainly can inform treatment recommendations when you go back on Monday to practice in your clinic. So we have a number of doublet options, certainly best supportive care, having a goals of care discussion with your patient in terms of the poor prognosis, as well as risks and benefits around the toxicities and benefits of chemotherapy is really important. As we move forward into improving upon these guidelines, as Misha said, we have many challenges just diagnosing the disease, understanding the AR indifference in our patients. It's about 20 to 30% of patients at autopsy, so this is not a small minority of patients. We have challenges, as Anna mentioned, of even defining the RB, P10, P53 losses, particularly in plasma testing. We have epigenetic work that is really defining the lineage plasticity. We understand that patients and their tumors, the spectrum exists from adenocarcinoma with AR-dominant luminal features to the neuroendocrine histology, and then everything in between, driven by stem cell phenotypes, lineage plasticity, Wnt signaling. As you can see in the map of all of our cell lines has really projected some intermediate states that are more stem-like. And what I'll be covering is the middle and the end of this lineage plasticity spectrum. But aggressive variant clinical criteria do not always align with the genomics nor the histology. We know that either by histology, gene expression profiling, phenotype, whether it's in the tumor or in a liquid biopsy, is all associated with a rapid progression and worse survival. What can we do about it? So level 2 evidence, as Anna mentioned, has come from platinum doublet chemotherapies. These are recommended at almost all guidelines with fairly robust responses, but unfortunately short-lived responses. So seeing an objective response is exciting, but is still met with great trepidation because we know that these benefits are short-lived, with median overall survivals of about 12 to 18 months and progression-free survivals about 4 to 6 months. And even within the platinum doublet treated patients, we see a spectrum of outcomes where small cell variants, bulky high-grade disease, and neuroendocrine markers are associated with worse survival even within this group. I do want to point out that, the aggressive variant features here are a larger piece of the pie, and small cell neuroendocrine is one component of this lineage plasticity. In Anna and Paul's phase 2 clinical trial, this was one of the only randomized trials that's been conducted in this disease. We do see that overall there's a progression-free survival advantage, but a modest survival advantage. But the important subgroups of patients defined by aggressive variant molecular phenotypes or clinical phenotypes led to a fairly dramatic improvement in progression-free survival as well as overall survival, particularly if 2 of the 3 tumor suppressors were lost. However, the predictors of platinum sensitivity haven't been clearly linked to p53-RB and PTEN loss. There was a case series of neuroendocrine prostate patients treated with platinum chemotherapy who had next-gen sequencing, and the PTEN, P53, and RB loss was not linked to the benefits of platinum directly. But 30% of these patients did have DNA repair alterations. RB loss and BRCA2 are actually co-localized on the same chromosome, for example. And the 30% of patients who had DNA repair deficiencies, 85% of these patients responded, including 100% of the BRCA2 germline somatic carriers. 70% of the patients without DNA repair alterations, only 30% responded. You can see the progression-free and overall survival differences between these groups really defined by, an actionable alteration in DNA repair alterations. This needs validation. When people have looked at predictors of platinum sensitivity, histology definitely seems to enrich, and the BRCA phenotype DNA repair alterations seem pretty similar in prevalence, whether you have neuroendocrine disease or not, in several case series. In our series, when we looked at a 10-year experience of platinum doublet chemotherapy, we did see that transformed neuroendocrine prostate cancer was associated with better response, but is not required for platinum sensitivity. BRCA2 and neuroendocrine prostate cancer, there seems to be some associations. In some initial studies, there was some confusion, but it seems in more recent data that BRCA2 carriers seem to be enriched in this lineage plasticity. Many of our cell lines that have BRCA2 loss have undergone lineage plasticity, for example. And about 26% of neuroendocrine patients at UW had BRCA2 loss versus 9% without, suggesting this enrichment of potential platinum sensitivity. I'm not aware of any really good studies, though, of single-agent PARP inhibition in neuroendocrine carriers, so we're mostly talking about platinum doublets. When you think about aggressive variant disease that's not neuroendocrine, I tend to think of these intraductal or ductal histologies. These are initial variants in initial diagnosis, and they tend to be AR low, and they tend to spread with a visceral tropic pattern. They have high CEA. They tend to not behave like luminal prostate cancer. And you see an enrichment in DNA repair alterations, suggesting that these patients may have an enrichment in platinum sensitivity. And thus a pretty strong recommendation here is to get molecular profiling, somatic and germline, as Heather mentioned, to help guide those treatment choices. And even serial testing may be helpful when you suspect lineage plasticity and transformation. What about immunotherapy in these aggressive variant patients? A UW case series identified that 40% of ductal cases, which again have aggressive variant features, have mismatch repair deficiencies. And this is a case report of an extraordinary responder to pembrolizumab who had ductal adenocarcinoma. Another small series out of Hopkins identified an enrichment of mismatch repair MSI-high disease in patients with ductal or intraductal histology. But it's very rare in neuroendocrine prostate cancer. When we looked at all of our patients at Duke and at UW in our Mr. T and UW databases, we only found one case. This is the case. This is our patient that we published a couple years ago as part of a clinical trial who had a CNS metastasis, transformed small cell prostate cancer. His CNS metastasis underwent NGS sequencing, and he had a MSH2 splice site. Lucky for him, he was able to access a PD-L1 inhibitor, went into a complete remission that's been durable for the rest of his natural life. He died of other causes. So there is hope. There are some patients that can benefit from this, but it's very rare. What else could we do besides platinums? Well, lurbinectidine is a marine derivative. It's derived from a marine tunicate. There's a picture of what that looks like. It's an oncogenic transcription factor inhibitor. It's actually approved in small cell lung cancer. It was approved based on a 105-patient single-arm study with an objective response rate of about a third, even though they were not very durable. And when we reported at the GU Symposium just this past year, we had data that lurbinectidine in small cell neuroendocrine prostate cancer, we had a very similar partial remission rate of about 31%, a partial progression-free survival, very similar to what you saw in small cell lung cancer. In my opinion, one of the best ways to treat neuroendocrine and lineage plasticity is to prevent it in the first place. Jiao Wang's lab identified several markers of neuroendocrine lineage plasticity, including CXCR2, nominating this as a potential factor that interacts with interleukin-8 to drive neuroendocrine transition. It's secreted by normal neuroendocrine cells and interacts in a paracrine fashion. CXCR2 inhibitors can prevent and delay neuroendocrine growth, as you can see here. Small molecule inhibitors prevent this, and these are immunocompromised models. I know there's a number of investigators exploring CXCR2 as an immunotherapy as well because of the direct impact on myeloid suppressor cells. And for both of these reasons, we've launched the Synergy 201 trial, which enrolls patients who do not yet have neuroendocrine disease but are at high risk of developing this, where we've combined enzalutamide plus SX682, a small molecule CXCR1/2 inhibitor, and this will be open through the DoD Prostate Cancer Consortium probably next month. This is a list of clinical trials that have been tested in prostate cancer, ranging from aurora kinase inhibitors, DLL3 inhibitors, PD-1 inhibitors, and a range of other epigenetic and genetic targeted therapies. I do want to point out that this is still a work in progress. The alisertib trial did not demonstrate sufficient activity in broad unselected patients. Rova-T, a DLL3 ADC, also was terminated due to futility. Our avelumab study as a single PD-L1 inhibitor also failed except for that one patient. We have an ongoing trial that I'll talk to you about in a second, and a number of these are ongoing. The CHAMP trial is our attempt to emulate small cell and non-small cell lung cancer by joining platinum doublets with dual immune checkpoint blockade. So building on Anna's study of Cabazi-Carbo, we've added Ipi-Nivo to engage T-cell exhaustion, recruit T-cells. I'm excited to say that stage 1 demonstrated lack of futility. That's about all I can say at this point. We've moved on to stage 2. We have success where we've met the minimal benchmarks, and we're going to be opening this with Anna as well as at Cornell. At MD Anderson, there's a number of approaches as well that are targeting EZH1 and 2. Looking at PD-1 and PARP inhibition to leverage some of the molecular phenotypes that we see in aggressive variant prostate cancer, as well as metabolic vulnerabilities with PEG arginase deaminase to really see if we can starve neuroendocrine tumors. I'd like to highlight Dr. Agarwal and Misha for attempting to develop immunotherapies against DLL3 and neuroendocrine prostate cancer. AMG 757, or tarlatamab, is a DLL3 bispecific T-cell engager. It lyses neuroendocrine cells that are DLL3 positive. Tarlatamab was recently given an FDA priority and breakthrough designation based on its activity in the Delphi 301 phase 2 trial in small cell lung cancer, where you see a substantial objective response rate, although short-term progression-free survivals with acceptable cytokine release syndrome toxicities. So this is under development. You'll hear a lot about this at ASCO. The bispecific T-cell engager, again, has demonstrated very clear preclinical activity in neuroendocrine prostate cancer, and we look forward to Rahul's phase 1 study. Misha has presented the Harpoon agent, HPN328. Again, preclinical data suggests very striking activity in DLL3 patient-derived xenograft models, and strong clinical activity in the phase 1 basket study, including GU patients with neuroendocrine carcinomas, and a confirmed response rate of 25%, overall response rate 58%. Exciting preliminary data that perhaps we can leverage our T cells to attack neuroendocrine tumors. I'd like to point out a nice target that the Jiao Wang lab identified, GPC3, which is an oncofetal protein. It's on the cell surface. It's not expressed in normal cells, as you can see in the middle map here. It's really focused on neuroendocrine prostate cancer, also liver cancer, and it's about a third of all of neuroendocrine prostate cancers have very bright GPC3. Targeting GPC3 kills neuroendocrine cells and reverses some aspects of lineage plasticity, and you can see in the xenograft models striking activity with GPC3 antibodies. We have started a 2024 PCF challenge, grateful to PCF funding for trying to develop an alpha particle radioligand therapy against GPC3, and Mike Hoffman as well, as part of his tactical award, is focused on GPC3 alpha particle development. Some ideas just to close. We need probably combination approaches for this disease. We don't expect there to be success with single agent therapies, but some novel radioligands, CAR T cells, BiTEs, and antibody drug conjugates, some of the nominated pathways and targets, GPC3, DLL3, CCAMs, CD46, as Dr. Agrawal has in development with the 446 compound, Bombacin, which is a neuropeptide, is currently under study in the COMBAT study. Using copper-67 and B7H3, as Misha has mentioned in her previous talks. You may need to upregulate some of these antigens through epigenetic modifiers to really have a synthetic lethal approach. There's also immune evasion. We still don't understand exactly how prostate cancer evades the immune system. Certainly it's not going to be as simple as giving a PD-1 inhibitor. We know that now. Myeloid suppressor cells seem to be the dominant immune evasion mechanism. So if we can overcome that, possibly through CXCR2 inhibition, perhaps with epigenetic agents to block the interplay between tumor cells, stromal, and tumor microenvironment cells, we may be able to overcome a real immune checkpoint in prostate cancer. Charles Sawyers and many other groups, Ping Mu, have demonstrated that JAK-STAT, as well as FGFR, drive lineage plasticity and the neuroendocrine transformation. And there actually is a small molecule inhibitor that blocks both of these pathways. It's demonstrated a fairly striking response rate and is now entering combination studies. Lurbinectedin, if you're certainly desperate and looking for an off-label solution, we have a number of targeted agents that can attack MECN, epigenetic disruption through EZH2 to redifferentiate tumors. Certainly you have to be ready as a tumor redifferentiates to inhibit the lineage plasticity in reverse. Through AR inhibition. The challenges, again, are disease plasticity, heterogeneity, as you can see in the cartoon over here from the figure of some of the seminal work. Many of these antigens, even in the same patient, can go down different routes. You can see tumors differentiate along either a neuroendocrine or a non-neuroendocrine spectrum, and as you block one, it can shift to the other side. So I think, in my opinion, in the end, would be combination approaches are likely going to be needed to attack both the AR positive and the AR negative components of prostate cancer to have a real effect. The conclusions, recommendations are, certainly, as I think you've heard, this is an aggressive phenotype associated with poor outcomes. We need to characterize these tumors better. Liquid and solid biopsies, maybe building on these biopsies to build better liquid biopsies would be helpful through the epigenetic and transcriptional assays. Molecular profiling is strongly recommended to uncover DNA repair defects. Certainly, that can reveal actionable alterations for platinum chemotherapy, for PD-1 blockade. And in the end, platinum chemotherapy is currently recommended, but clinical trial enrollment, I think, is what's going to really move the needle for these patients. And we need really validated clinical biomarkers, either novel PET imaging, blood or tissue biomarkers, to really refine the patients eligible for these studies. Thank you.
Thank you. Open it up for questions. I'll start. Heather, so it was an excellent talk. I'm curious about, you mentioned when a somatic test would prompt germline testing, and what do you think about germline testing prompting somatic testing? Do you need to confirm LOH in the tumor? Are both always required?
Yeah, I think it's a really good question. I think it goes back to what the disease setting is. If it's an MCRPC, I think because there'll be additional alterations not limited to what would be found on germline, I think I would strongly recommend doing tumor testing as well. So I think really asking the question of what is the potential actionability at the time, and then looking carefully at the limitations of the assay. And And in some cases, like for example, BRCA2, we know that by and large, there's always some second allele inactivation, and the suspicion is so high as you almost don't need to confirm it by tumor testing. But some of these other genes like CHEK2 or ATM, those, I think we still have a long way to go to try to understand what they really mean in terms of actionability. And I think, that's going to be the work that, in the session yesterday, Joaquin and Johan talked about. I think we do need to do more work on that to understand it better.
Good morning. These were all great presentations. My question is predominantly directed at you, Misha, but I think anybody could help answer. So thank you for highlighting 90203, interesting trial, which I worry a little bit is going to leave the field with the perception that we shouldn't pursue docetaxel in high-risk localized disease, when in fact there was a signal there. But my question is I wonder what you see in the genomic data with regards to chemotherapy sensitivity or chemotherapy resistance, or other factors from that data set that you analyzed that may help us do treatment intensification in that high-risk localized patient population, where I think we have an opportunity for future cures.
Yeah, thank you for the question. I think that the neoadjuvant space is such a rich space for looking at tissue markers, and so we've been looking mostly at the residual tumors after treatment, so it's hard to assess responders. We are going back to the biopsies and running Decipher, and I think that'll be really interesting to correlate with the stuff that Gert and Chris Sweeney have been working on in the metastatic space, and also looking at Artera to say, are there prognostic variables in that setting, or maybe variables that could predict response to neoadjuvant therapy, looking at the tumors. But in the residual tumors, I mentioned that there was enrichment of P53 mutations, mainly probably because those are more resistant to the docetaxel ADT. Martin Glebe does have a neoadjuvant study, GUNS trial, that's looking at specific molecular biomarkers, including docetaxel plus an AR pathway inhibitor, a more potent triplet type therapy. So I think we'll learn from that too. I don't know I think mostly we've seen how the genomics in the post-residual tumors, what's left, which I think may inform metastatic disease. One of the interesting findings from that was also the use of tumor cellularity or tumor fraction by genomics, because path response is an important endpoint for all these neoadjuvant studies, and could we be a little bit better at quantifying that? So I think more to come by GUNS as well as others, and I encourage everyone enrolling in neoadjuvant studies to think hard about collecting those tissues.
It's good to see that we haven't entirely given up on treatment intensification in localized disease. Thanks.
Thank you.
Hi, I'm Mutambirwa from South Africa. It's a sort of a practical question for me. We have little access to PARP inhibitors. They're expensive, and they've also got issues with the side effect profile. Is there any data, I know it's probably a dearth of data, about using carboplatin rather than PARP inhibitors as monotherapy, and can they be sequenced at all? Because if they're not going to be able to be sequenced, maybe just carboplatin with its side effect profile might be a better option than a PARP inhibitor.
You want to do it?
Sure, I can start. Maybe I'll start.
You've got some data.
Yeah, so I think we do have some limited data. Prospective studies are going to be reported soon, but I completely agree that carboplatin is generally available, with the exception of when there's shortages, less expensive, and I think likely to be also in the treatment toolbox. So if PARP inhibitors are not possible, I think, or feasible or accessible, then carboplatin is certainly a good option. And I think, other cancer type, tumor types that involve the same DNA repair alterations like ovarian cancer and pancreatic cancer are also standardly treated with platinum. So I think definitely good to keep in mind. And then there's a study through the VA called COBRA, which is looking at sequencing of PARP versus platinum, and I think it'll be interesting to see what that shows.
Mm-hmm.
Gert Attard, excellent morning. I have a request for Heather. Can you expand on digital tools we can use for genetic counseling? Because I think where we want to land is this is a reflex test, and then patients opt out. But to really scale this up, what are your thoughts on doing?
Yeah, I think there's a lot of opportunity, and I was really excited in yesterday's session. I mean, we've done some early, I think Lisa Horvath is in the audience in Australia. They did mainstreaming. Memorial's done mainstreaming. Mary Ellen Taplin's done ProGen at Dana-Farber. I think, Stacy Loeb and Veda Giri and I and others have worked on web tools. I think the key is going to be trying to offload and automate using AI, using chatbots, in order to not miss anyone. But I do think that we are still going to need some conversations. That may get a third of patients or maybe a quarter of, some fraction of patients will be early adopters and will do that, and then you can reflex to genetic counseling for pathogenic carriers or those who have a really strong family history. But there will still need to be some patients who need an individual discussion and who still do need sort of classic genetic counseling. So I think the field needs to really be looking at how to do this in a patient-centered way. But I think some of the AI technologies are really going to help. And I was talking to Nick James yesterday at the dinner about just the opportunities, even thinking about being creative in maybe resource-limited settings or in developing world where there's a lot of smartphone access. Could we begin to sort of develop and pilot and collaborate together on ways to sort of ensure that no one gets left behind, but then also be able to meet patients where they are and give them more dedicated counseling? So great question.
Dan.
Yeah, hi, two quick questions. One for Andy, with all these fantastic studies going on, great talk, but right now, today, is there any role for SBRT or other types of radiation as a consolidation? We talked about doing PSMA PET in our metastatic hormone-sensitive settings to find the tumors to consolidate. Can you take a kind of a FDG approach to that in neuroendocrine? I mean, I know there's not necessarily studies, but what can we do on a practical level?
Yeah, I certainly think Prostate Cancer Working Group 3 and 4 will emphasize to treat until patients no longer clinically benefiting. And when you see oligoprogressive disease where that clone is emerging that seems to be behaving badly, and if it's oligo, certainly applying a focal therapy may allow the patient to experience more disease control. So that's theoretical. We actually have no data, but I think it's reasonable clinically to apply those same approaches that we've learned from regular prostate cancer.
Great. And then a quick question for Heather. So, I think we're kind of over the stigma of genetic testing, everything. Are we ready to just do germline in everybody? The cost is down. What's the downside?
Yeah, I think this is a great question. So I think in the future, I hope that that's going to be the case. And I think that's something we can move towards. I don't personally think we're quite ready. And I think there's a lot of, the devil is in the detail. So there's a lot of potential for confusion, for harm, for misunderstanding. Variants of uncertain significance need to be removed if we're going to be really mainstreaming on a really broad level. And I think we still have to focus on people for whom there's more likely to be an actionable finding or a germline variant, metastatic, high-risk, localized, strong family history. If we can get that right, if we can, expand on what Garrett was talking about and others have been working on, and I think as a community we could really hopefully be looking carefully and refining that, then I think we can open the floodgates. But I don't think we're there yet. I think we need to be very careful because you can't stop the spigot once you sort of open it up. So I think we need to go slowly, but I think the future may include some version of that.
Can I comment real quick on the first question? I think for primary small cell prostate cancers, they frequently present with very bulky primary tumors and extremely symptomatic tumors. There are obviously generating prospective data for this is very, very complicated, but we did publish a retrospective study where people that got radiation to their primary tumor in that context did better. And anecdotally, obviously you have people that don't get it and have miserable times later on. So for primary small cell prostate cancers, I strongly recommend consolidated radiation to the primary at the time of best response.
Last question.
Yes, thank you. Thank you for these outstanding presentations. I'm a nuclear medicine physician in Brussels, and we are frequently facing, of course, aggressive variants of prostate cancer. We can do PSMA, FDG. Sometimes some patients we did dot-8 PET. So I like to call it like molecular profiling, molecular imaging profiling, because you can already see these different characteristics of different patients with aggressive variants, and you see this heterogeneity of disease. Maybe sometimes guiding biopsy to specific spots. So I saw these trials ongoing, and on none of them molecular imaging is included. How can we merge these both, let's say, worlds of molecular imaging profiling with genetic testing?
I would just completely agree. With the PET scans, it's really been fascinating to see the heterogeneity, and I think within the context of CRPC studies as well as neuroendocrine or aggressive variant studies, we should be incorporating PSMA PET, FDG, and other assays, and to be able to really capture what the disease is doing way better than a biopsy would. So I would hope to see that in future studies.
The DLL3 PET is only right now available at, I think, 1 or 2 institutions. So rolling that out, validating it in a multi-institutional cohort will be very important.
So there's an issue with cost. Number one, when you run clinical trials, to get all this PET imaging is a problem. And I think that PET imaging is basically another biomarker. Absolutely needs to be prospectively studied, but it has to be prospectively studied as a biomarker.
We just say APCCC diagnostics next year. So I think it's going to be a very important part of that. So we have some few questions, but I would really like you to stay because before the coffee break, we heard there will be a PSMA surprise. So stay and don't go and have coffee now. So we start with the questions, and this is probably interesting for you, Heather. You see here we asked the question about genetic evaluation, and this one here is high-risk localized locally advanced prostate cancer. And you see that 30% of the panelists do germline testing in these patients. 14% do somatic testing and then add the germline testing if there are findings. 21% say both tests, like you did when I understood correctly. And 35% said no. So Dan George, we are, it's not only the patients, it's probably also the doctors. If we go to the next stage, metastatic hormone-sensitive disease, that changes. So 16% germline testing, 25% somatic testing, and then germline testing if findings, 42% both, but still 17% say no. And in MCRPC, that changes again completely, only 5% saying no. I don't know. Heather, can I ask you to comment?
Yeah, I think this, this is based on personal history of prostate cancer. It doesn't reflect family history. That's one thing. The other thing is I think it probably also reflects payer coverage, which varies country to country, and also the availability of clinical trials. I think certainly if there's clinical trials, then there's more motivation. As I was mentioning, there's more actionability. So I think this is going to be evolving over time.
So we assumed that all the tests and all the resources were available. But it's good to see here in this question 103, I remember when we first discussed it at APCCC, Ross Eels was really heartbroken when we did not reach a consensus on, recommending germline testing. And now we see a lot of blue and a lot of yellow in this question, in MCRPC at least. Two last questions that we have asked previously, so they keep popping up. And it also goes into the talks that we have heard this morning. And this is outside of a clinical trial for patients with MHSBC. And we asked, does the genetic evaluation, germline and or somatic, influence your treatment decision? Again, assuming everything is available without testing. And at the moment, only a minority, 24% of the panel said yes. And there's a consensus actually for MHSBC that this information should not influence your treatment decision. And when we go to MCRPC, the picture changes completely. I think this also was discussed yesterday in the PARP session. 80% said yes, of course, this information influences your treatment decision. 20% voted no. I don't know. Anna or Andy, do you want to comment on? You've been advocating testing and taking decisions.
Yeah, I mean, I think germline, absolutely, I think we do on pretty much everybody. But for somatic, I think it's important to consider the actionability of your test result. And One thing that I think has been alluded to is sort of the financial, first of all, the availability, but second, the sort of the financial toxicity of repeating these tests multiple times. So I tend to request somatic sequencing for first-line treatment of metastatic castration-resistant disease.
And something I learned from Misha again is no dye test. No, it's more complicated than you sometimes think.
I think for me, just because of the approvals in the first-line CRPC setting and some of the logistics of getting the sequencing done in time, I often initiate the process in metastatic hormone-sensitive prostate cancer, using primary tumors, and if that's unsuccessful, then doing a ctDNA or a biopsy later. So I think maybe that's where the question, you see variability in when the testing is done, but not necessarily when the treatment is initiated.
We did ask about when to test last time in 2022. There was a clear picture that some do it in MHSPC, most do it in mCRPC, and here we want to really stress the point, should it influence your treatment decision? Should you, use TP53, P10, RB1 loss to, I don't know, change your treatment or not?
I think the other thing for me that I've observed is there's so much change in the field, right? We're learning about all of these things so quickly, and if somebody has relatively indolent disease or they're in hormone sensitive with what good disease control, it could be years before you need that information, right? And so if that's true, sometimes the testing, the leading edge of the technology and what we're learning has moved so quickly, it's a balance of trying to sort of account for the turnaround time, but then also the innovation that is going to happen. So I think that I don't have a good answer for it, but I think, yeah.
Can I follow up on that? Would you then in MHSPC just do the germline? Because we had Swiss guidelines where it said tumor testing first for germline evaluation. So we had to go through somatic profiling before we could do the germline. And then, as you said, it may be in an MHSPC patients many years before the somatic information
if actionability is not immediate, then perhaps, yes, there's an argument to be made for doing the germline first and then waiting.
Anna?
Andy, you just published a series discussing also the sort of evolution of the disease and the findings of new alterations that may impact your treatment decisions during the progression.
Yeah, that was our data from the somatic promise. You have the germline promise, so not to confuse the two promise registries, but this is over 2,000 patients across academic centers, and we found that serial ctDNA testing, particularly in the CRPC setting, identified actionable alterations defined as BRCA or MSI, very strict, in about 11% of patients. So for those 11%, that's game-changing for them, and certainly in the first-line setting, if you haven't had an ARPI, then it does guide therapy, as you heard yesterday.
Yep.
Ready for the surprise?
Ready for the surprise? Yes. Okay. Me too.
Okay. Before you send everyone to the coffee break, I know that you like a good aperitivo, right? Yes. So we thought we might serve you an aperitivo before the next session. Those guys here, they had a mega hit in 1978. Some of the faculty, they may remember it. I was barely born. And just after well, miraculously, those guys, they actually predicted what would be the hot topic in prostate cancer in 2024. Can you hear it? PSMA. Yeah, right. And guess what? There may be a dance routine emerging for this as well. And where would be the better time and place than here at APCCC and today to show this for the first time? But for that, I would need a little bit help from some of the PSMA guys. So can you come up here? Stefano, Ken, Luis, and Michael, come up here on stage with me. Come on, Mike, as well. Perfect. So come up here. And I'm going to show you how it's look like. It's going to look like this. P, S, M, not like this, it looks like a monkey, M, and A. Okay, can we do everyone like this? Oh, the S is perfect, yeah. P, S, M, A. Okay. Should we do one dry run? So first the Instagram picture, yeah, right. P, S, M, A. Okay. So one dry run. Should we try all together? So come on, get up on your feet. All together. So, everyone with me. P, S, M, A. Once more. P, S, M, A. Wonderful. Should we do that? Should we do it with music? Yeah. With music. So, carefully, it starts right away with a P. But music without lyrics, it's only half the fun, right? It's only half the fun. So that is why we asked our very own APCCC singer and songwriter, Joe Sullivan, to rewrite lyrics for this. And they come here. And we want you all to sing along and dance along with us. And when I start the music, I only forget one thing. Right. I know I said no costumes yesterday. I know I said no costumes yesterday. Okay, can we start the music, please, and everyone sing along and dance along. Get up on your feet again. Very much. Have a nice coffee break. Thank you very much. Have a nice coffee break. And see you all again here at 11:15.